Welcome to the Deep Dive. Today, we're cutting through the noise to understand a condition many of us have heard about, but maybe don't fully grasp its hidden dangers. Hypertension.
Yeah, high blood pressure.
Exactly. It's often silent, but it's a major risk factor for really serious things like stroke and heart attacks. A quiet threat, but one that definitely demands our attention.
And that's absolutely why this deep dive is so important. High blood pressure is incredibly common, but really understanding the nuances, what it actually is, the different types, how it affects your body, and crucially, how it's managed well, that's vital for anyone wanting to be truly informed about their health.
Right, like having the inside scoop on your own body.
Precisely.
Okay. So our mission today, using the source material we've got, is to unpack the essential knowledge, maybe reveal some surprising facts, and really pull out the key insights. So by the end of this, you'll feel confidently informed about hypertension. All right, let's get into it.
Let's do it.
So starting with the basics, what exactly is hypertension? And how do doctors actually diagnose it? We hear numbers like 120/80 thrown around. What are the real thresholds?
Well, fundamentally, hypertension just means your blood pressure readings are consistently, persistently too high.
Okay.
According to the British Hypertension Society, what's called mild hypertension, or grade 1, kicks in when readings are persistently above 140/90 millimillig.
140/90. Got it.
Yeah. And ideally, optimally, you want to be below 120/80 millimillig.
Right.
Now, the diagnostic process itself is quite careful, which is interesting. It's not just a single quick check.
Uh-huh.
They check the pressure in both arms. If it's high, they'll have you rest for about 5 minutes and then check again.
Okay.
And here's the crucial part. It's only confirmed after you have 2 or more elevated readings across different office visits.
Ah, so it's about the pattern, not just one potentially stressful moment.
Exactly. That thoroughness is really important.
I guess that helps avoid diagnosing someone just because they have that white coat thing.
Precisely. That careful process helps rule out white coat hypertension, where your pressure spikes just from the anxiety of being in a clinic.
Yeah, I can see that happening.
So for those situations, monitoring blood pressure at home or even using a wearable monitor for 24 hours, that's called ambulatory monitoring, can give a much more accurate picture of what's really going on.
Makes sense. Get the real world data.
It's all about getting the most accurate reading for you.
Okay, so once someone does have that confirmed diagnosis, the big question is,
Yeah.
why? Our sources mention 2 main categories, right? And one is much, much more common.
That's right. The vast majority, we're talking about 90% of cases, fall into the category of essential, or sometimes called primary, hypertension.
Essential. Okay.
And the simple truth there is, for these cases, we can't actually pinpoint one single specific underlying cause.
Huh. So it's not like one thing broke.
Not usually, no. It's typically a combination of factors. Things like getting older, smoking is a big one, having diabetes, increased stress levels, obesity, a diet high in sodium.
The usual suspects, kind of.
Pretty much. And there's often a genetic component, too. If your parents had high blood pressure, you might be more prone. This type usually shows up between ages 25 and 55 or so.
So for most folks, it's this mix of lifestyle, genes, maybe age, no single smoking gun. But what about that other 10%? That sounds like where things get, well, more specific.
Exactly. This is where it gets really interesting, medically speaking. That other 10% is secondary hypertension. And that means there's an identifiable underlying cause we can point to.
Okay.
We often start suspecting this if someone's blood pressure is really stubborn, what we call refractory hypertension, meaning it's not controlled even with 3 or more different types of medication.
Wow. 3 or more. So the body's really fighting the treatment.
Right. And that's when the medical detective work really begins, trying to find that root problem. And the causes here are fascinatingly diverse.
Okay, I'm intrigued. What kind of things are we talking about?
Well, first off, kidney problems. Things like chronic kidney disease or a narrowing in the arteries supplying the kidney's renal artery stenosis.
These can activate the body's own blood pressure regulation system, the renin-angiotensin-aldosterone system, or RAAS, essentially putting it into overdrive.
So the kidneys are kind of hitting the gas pedal by mistake.
That's a great way to put it, yeah.
Yeah.
Then you've got endocrine disorders, problems with hormone-producing glands.
Like thyroid.
Exactly. Both an overactive and an underactive thyroid can mess with blood pressure, interestingly. Also, the adrenal glands, which sit on top of your kidneys, if they produce too much of certain hormones, like aldosterone or cortisol, that can drive pressure up too.
Hormones playing a big role, okay?
Then there are even neurological disorders, conditions that significantly increase the pressure inside your skull. Think brain bleeds, swelling, maybe a tumor.
Serious stuff.
Very serious. This can trigger something called Cushing's triad. It's like a critical alarm from the brain. Heart rate slows way down, blood pressure spikes dramatically, and breathing becomes irregular. It's the brain's drastic response to extreme pressure.
Wow, that sounds intense. What else? It doesn't stop there. You can have aortic diseases, like a narrowing of the aorta itself, the main artery from the heart, that's called coarctation. That can cause really high pressure in your arms, but strangely low pressure in your legs.
Weird. Upper body high, lower body low.
Exactly. Then, in pregnant patients, there's preeclampsia or eclampsia, which involves new high blood pressure, often with protein in the urine and swelling. It's linked to issues with blood supply to the placenta.
Okay, specific to pregnancy.
Right. And then things people might do to themselves, substance misuse. Stimulants like cocaine or amphetamines directly activate the sympathetic nervous system, your fight or flight response, and that jacks up blood pressure.
Makes sense.
And finally, something increasingly recognized, sleep apnea. Those periods where you stop breathing during sleep cause drops in oxygen, which, again, kicks that sympathetic nervous system into gear, leading to high, often refractory, blood pressure.
It's amazing. The sheer range of things, kidneys, hormones, brain pressure, sleep, it really shows how interconnected everything is. That sleep apnea one is particularly striking.
It really is. It highlights how something seemingly unrelated can directly impact your cardiovascular system.
So, okay, we have all the potential causes, this relentless high pressure. How does that sustained strain actually damage things? What's it doing to the organs day in, day out?
Yeah, think of your circulatory system like complex plumbing. High pressure forces the pump your heart and the pipes your blood vessels to work way harder, constantly.
Right, nonstop stress.
Exactly. The vessels themselves start to thicken and get stiffer, which increases resistance. It's harder for blood to flow.
Like squeezing a hose pipe.
Sort of, yeah. And your body's stress response, that sympathetic nervous system we mentioned, often stays ramped up, keeping vessels constricted. Plus, the body tends to hold on to more sodium and water, which increases the actual volume of blood the heart has to pump around.
So, more resistance and more volume. Double whammy for the heart.
Precisely. It's just under constant strain. And over time, that strain leads to damage.
Okay, that makes the mechanism clear.
Right.
And this constant strain, this pressure, I imagine it leads to some pretty severe consequences down the line, potentially even that hypertensive emergency you mentioned if it gets really bad. What specific parts of the body really take a hit?
Absolutely. And the scary part is this damage often happens silently, without any symptoms until things are quite advanced. That's the silent killer aspect.
Right. So where does the damage show up?
Well, pretty much everywhere, but key targets. In the cardiovascular system, the heart's main pumping chamber, the left ventricle, can thicken from the extra workload. That's left ventricular hypertrophy, or LVH.
Yeah.
That can lead to heart failure, especially diastolic heart failure where the heart can't relax properly. It can also cause fluid backup into the lungs, acute pulmonary edema.
Not good.
Not good at all.
Right.
High pressure also accelerates atherosclerosis, the hardening and narrowing of arteries. That means coronary artery disease, angina, heart attacks, blockages in leg arteries. The whole spectrum.
Wow.
And the sheer force of the blood flow, the shearing stress, can even cause the aorta to tear or bulge. That's aortic dissection or aneurysm.
So the main pipe itself can fail.
Yes. Then, moving to the brain and nervous system, hypertension is a huge risk factor for stroke, both ischemic strokes from blockages and hemorrhagic strokes from burst vessels.
Yeah.
Really severe high pressure can cause confusion, seizures, or a specific type of brain swelling called PRES, posterior reversible encephalopathy syndrome.
PRES. Okay.
In the kidneys, the high pressure damages the tiny filtering units, the glomeruli. This can lead to chronic kidney disease or even acute kidney injury. You might see blood in the urine, hematuria.
So it damages the filters.
Exactly. And even your eyes aren't spared. The delicate blood vessels in the retina get damaged. That's hypertensive retinopathy. It ranges from subtle thickening to bleeding, those cotton wool spots you hear about, and in severe cases, swelling of the optic nerve, papilledema, which can affect vision.
Goodness. Heart, brain, kidneys, eyes. It really is systemic. It hits everywhere, which just hammers home how vital it is to manage it. So that leads to the crucial question, what can we actually do about it?
Yeah. That's the critical next step.
Given how damaging this can be, what are the first steps, the fundamental things patients need to do, and then what does the pharmacological toolkit look like?
Right. So absolutely foundational for everyone, regardless of their blood pressure level, even if it's normal or just borderline, are the general measures and lifestyle modifications.
Okay, so this isn't just for people with hypertension.
Not at all. These are crucial for prevention, too. We're talking about weight reduction. Even a modest weight loss can make a big difference.
Really? Even just a bit?
Absolutely. Dietary changes are key. Moving towards a mixed diet packed with fruits and vegetables, seriously cutting back on salt intake, limiting saturated fats. The DSH diet is a well-known example specifically designed for this.
DHH.
Right.
Dietary approaches to stop hypertension.
That's the one. Regular physical exercise aiming for at least 20 minutes, maybe 3 times a month, is vital. Moderating or ideally eliminating alcohol, and of course, smoking cessation. That's huge.
Okay.
These steps alone can sometimes be enough to control mild hypertension or certainly prevent it from developing.
So lifestyle first. Always. But what if that's not enough or the hypertension is more severe? What about medications?
Then we move to pharmacological management. And the key here is that the choice of drug is very personalized. It depends on things like your age, your ethnic background, and any other health conditions you might have comorbidities.
Right. Not one size fits all.
Definitely not. There are several main classes of drugs, each tackling blood pressure from a different angle.
Okay, like what?
First, you have sympatholytics. These basically work by calming down that sympathetic nervous system, the fight or flight response.
Dialing down the stress response.
Exactly. This group includes things like beta blockers. They slow the heart rate and relax vessels. There are also alpha blockers, which mainly relax blood vessels. Some drugs act centrally in the brain, too.
Okay. And I've definitely heard of diuretics, the water pills.
Yep, diuretics are very common. They help your kidneys flush out excess sodium and water from your body.
Less fluid, less pressure.
Simple as that, basically. Thiazide diuretics are often a first-line choice for uncomplicated essential hypertension. There are also more potent loop diuretics for situations with fluid overload and potassium-sparing ones, too.
Got it. What else?
Then there are the RAS inhibitors. These target that renin-angiotensin-aldosterone system we talked about earlier, the one that kidneys can mistakenly activate.
Yes, the one that hits the gas pedal.
Exactly. So these drugs block that system. The main types are ACE inhibitors and ARBs angiotensin receptor blockers. They're very effective.
I've heard ACE inhibitors can cause a cough.
They can, yes. A persistent dry cough is a well-known side effect for some people. If that happens, switching to an ARB often solves it, as they work slightly differently but target the same system. Both can sometimes affect kidney function or potassium levels, so monitoring is needed.
Okay. And the last group?
Finally, we have vasodilators. These work by directly relaxing the smooth muscle in the walls of your blood vessels, making them wider.
Opening up the pipes.
Pretty much. This includes calcium channel blockers, which are very widely used. Some mainly relax arteries, others also slow the heart rate. There are also direct-acting vasodilators like hydralazine or nitroprusside, often used in more urgent situations.
Wow, quite an arsenal.
It is. And each class, each drug, has its own profile of potential side effects. But having these different options means doctors can usually find a medication or combination that works well for an individual patient.
It really underscores how tailored the treatment needs to be, which leads perfectly into this idea of precision, how doctors choose which drug for which person, especially if they have other health issues going on. That's fascinating.
It really is. This is where treatment becomes highly individualized. For example, if someone has tachyarrhythmias fast, irregular heartbeats along with high blood pressure, then beta blockers or certain types of calcium channel blockers, the non-dihydropyridine ones, are great choices because they help control both problems simultaneously.
Killing two birds with one stone.
Exactly. Similarly, if you have coronary artery disease, maybe you've had a heart attack or you have heart failure, beta blockers and ACE inhibitors or ARBs are often strongly recommended because they have proven benefits in protecting the heart in those situations beyond just lowering blood pressure. Sometimes aldosterone antagonists are added too.
So they're not just lowering pressure, they're actively protective for the heart condition itself.
Precisely. And for patients with diabetes or chronic kidney disease, ACE inhibitors or ARBs are often first choice.
Why is that?
Because they have a specific beneficial effect within the kidneys, they reduce the pressure inside the kidneys' filters, which helps decrease protein leakage into the urine and, crucially, slows down the progression of kidney disease.
That's a huge benefit beyond just blood pressure.
It really is. Then there are other interesting overlaps. For men with benign prostatic hyperplasia, BPH, an enlarged prostate.
Yeah.
Certain alpha blockers can actually help improve urinary flow while also lowering blood pressure. A nice 2-for-1.
Handy.
And for someone with osteoporosis, thiazide diuretics can be a good choice because they actually help the body reabsorb calcium, which might help with bone density.
Wow, I wouldn't have expected that link with calcium. What about special situations like pregnancy or people with lung conditions?
Yeah, those require careful consideration. During pregnancy, patient safety is obviously paramount. Some drugs like hydralazine, methyldopa, labetalol, and nifedipine are generally considered safe.
Okay.
But ACE inhibitors, ARBs, and diuretics are usually avoided because they can potentially harm the developing baby.
Right. Makes
Right.
sense. And lungs.
For patients with conditions like COPD or asthma, doctors are generally cautious with ACE inhibitors because of that potential cough side effect, which could be confused with worsening lung symptoms. And non-selective beta blockers are usually avoided because they can potentially trigger bronchospasm, making breathing difficult.
So lots to consider there. Even ethnicity plays a role, you mentioned.
It can, yes. For instance, in non-elderly patients of African American background, hypertension often has what's called a low renin profile,
Low renin. Okay.
which means that ACE inhibitors or ARBs might not be quite as effective as first-line therapy compared to, say, calcium channel blockers or thiazide diuretics. So guidelines often reflect that. And in elderly patients generally, calcium channel blockers are often a preferred starting point.
It's incredibly personalized. It really drives home that the treatment plan has to be built around you, your age, background, your other health conditions. It's quite impressive.
It's a great example of how medicine aims to tailor treatments for the best individual outcomes.
Okay, so we've covered managing chronic high blood pressure really thoroughly. But what happens when things go acutely wrong? When the pressure spikes dangerously high? What's the difference between a hypertensive urgency and an emergency?
This is a really critical distinction, and it all boils down to one thing. Is there evidence of acute, ongoing target organ damage right now?
Okay, organ damage is the key.
Exactly. A hypertensive crisis is generally defined when the blood pressure is severely elevated, typically greater than 180 systolic or 120 diastolic. So above 160 Sir zone 120.
That sounds very high.
It is. Now, within that crisis level, you have the two categories. Hypertensive urgency means the blood pressure is that high, yes, but there's no sign of acute damage to vital organs like the brain, heart, kidneys, or eyes.
So high numbers, but the organs seem okay for now.
Right. It definitely needs attention, needs to be brought down, but it's typically managed with oral medications, aiming for a gradual reduction over maybe 24 to 48 hours. There isn't that immediate life-threatening organ damage happening.
Okay, urgent, but not necessarily emergent.
Precisely. A hypertensive emergency, on the other hand, is when that severely high blood pressure is causing acute or impending damage to those target organs.
Okay, this is the really bad one.
This is the one that requires immediate action. You might see signs of stroke, heart attack, acute kidney failure, pulmonary edema, or changes in the eyes like papule edema. This is a true medical emergency.
Right.
It requires urgent treatment, usually with intravenous IV medications, typically in a hospital, often an ICU setting, to prevent further damage.
And you need to get the pressure down fast.
Carefully fast, that's the crucial part. The goal is generally to reduce the mean arterial pressure, the average pressure, by about 25% within the first hour or two.
Okay, 25%.
And then aim for a target like 160 over 100 millimilli over the next 2 to 6 hours. And this is vital, lowering the pressure too rapidly can actually be dangerous.
How so?
If you drop the pressure too quickly, you risk underperfusing vital organs, essentially causing ischemia or lack of blood flow to the brain or heart because they've adapted to the higher pressure. So it's a very controlled, gradual reduction.
A delicate balancing act, even in an emergency.
Absolutely.
And are there specific IV drugs used for different types of emergencies?
Yes. The choice of IV agent often depends on which organ system is being affected. For neurological emergencies like a hypertensive encephalopathy or stroke,
Yeah.
drugs like nicardipine, which is a calcium channel blocker, or labetalol, which has both alpha and beta blocking effects, are often used because they allow for smooth, controllable pressure reduction.
Okay. What about heart issues?
For cardiovascular emergencies like an acute coronary syndrome or heart failure, drugs like esmolol, which is a very short-acting beta blocker, or labetalol again, or sometimes low-dose nitroglycerin are used. They reduce the workload on the heart as well as the pressure.
Right.
For an aortic dissection, that tear in the main artery,
Yeah, that sounds critical.
It is. The primary goal there is to reduce the shearing forces on the aortic wall very rapidly. So drugs like esmolol or labetalol are used aggressively to lower both heart rate and blood pressure quickly.
Get that force down immediately.
Exactly. And for something called flash pulmonary edema or escape, where fluid suddenly floods the lungs due to high pressure,
Uh-huh.
high-dose nitroglycerin is often the drug of choice because it's a potent vasodilator, relaxing both arteries and veins, which helps pull fluid out of the lungs very quickly.
Wow. Specific tools for specific crises.
Hmm.
It really highlights how critical it is to know the difference between urgency and emergency and to get immediate help if organ damage is happening or threatened. That knowledge could absolutely save a life.
Without a doubt, time is critical in a hypertensive emergency.
Well, we've really covered a lot of ground today. It feels like we've taken a truly comprehensive journey, right from the basic definition of hypertension through its, well, incredibly complex causes, its profound and wide-ranging effects on the body, and these highly personalized ways of managing it, even in a crisis.
Yeah, it's a huge topic.
It really is. And understanding a condition like this, in this kind of detail, it genuinely feels like a shortcut to understanding your own health much better.
I agree. And it's not just about memorizing facts. I think understanding hypertension helps you appreciate the sheer complexity and, frankly, the resilience of the human body, and also the progress that medical science keeps making.
Absolutely.
That knowledge really empowers you, I think, to engage more meaningfully with your own health journey. You can ask better questions, make more informed choices alongside your doctor.
Well said.
Yeah.
So, to leave everyone with something to think about, given how silent and, frankly, how common hypertension is, what steps could you, listening now, take today to maybe get a clearer picture of your own cardiovascular health? And how might knowing that, how might that knowledge empower you in the long run?